Just waiting to go live on YouTube and then we will kick off. Good morning, everyone, and welcome to CAHN's Health Hour. We've been running this since the beginning of May. We've had some great, professionals and consultants from our community, coming on to engage with the community. And this morning, we're delighted to have someone who has been with us right from the time we launched as CAHN and continues to support us in diverse capacities, with so many years of experience in the city of Manchester. We're delighted to have Dr. Ngozi Edi-Osagie with us, consultant neonatologist, who will introduce herself and then do a presentation, after which she will take questions from the floor. So over to you, Ngozi.
Thank you very much, Charles, for your introduction. Yes, as he says, my name's Ngozi Edi-Osagie, and I'm a neonatologist. And I thought I should explain a bit about what being a neonatologist is. I've been really, I'd say, privileged to be part of CAHN's journey from the launch event where I presented. I've also been quite privileged to have somebody who is my chief supporter, my mum, who's on the call today and is generally at anything I'm doing where she can be. So that's also nice to have. Having a parent who lives in the same city is great. And I know that not everybody has that good fortune. So Charles asked me earlier this week about talking to you here at CAHN. I have organized lots of my colleagues to be on this call before and to share their expertise in different areas of medicine. And he said to me, you haven't done it. And I thought, well, yes, I haven't. And that's because, in a sense, I always feel that people want to know about themselves, about healthcare that might affect them. And I deal with children. And generally, I think when your child becomes unwell at a later stage, then you're happy to take them to a pediatrician. But I'm the pediatrician that nobody wants to see. When people, when a woman gets pregnant, your hopes and dreams for that pregnancy are that you will end up taking home a baby who is healthy. And most people don't think about anything that can go wrong with that pregnancy, either halfway through or after you've had the baby. So when you come into hospital and you're about to have your baby, which you've envisaged that nothing will go wrong, and they suddenly say, we need to call the pediatrician, it's usually a moment of dread for most parents. So I'm not usually the doctor that people expect to see or are happy to see. However, if your baby is not well, then of course I'm welcomed into the room. But when you start off being pregnant, it's not the end that you want. So as a neonatologist, I trained as a pediatrician, but I did some extra training to look after babies at the beginning of life. So I mainly deal with premature babies. So this is babies who have come too early. And as you know, a pregnancy lasts for 9 months. So my area of expertise is in looking after babies who have come long before the due date. And that is, I've looked after babies from 22 weeks gestation. So that would be a baby who was born today, who was expected to be born in January. So this is really premature, right up to babies who are born on time, but babies who are unexpectedly sick when they're born. I'm also involved sometimes antenatally, because for those of you who've had babies, you will remember that you'd had some scans, and the scans are to look at any possibilities of malformations or problems that we might expect in the baby. So there are a small group of babies who we identify problems before they're born. And so I would get involved at that stage and counsel parents about what to expect after birth and the sorts of things that we would do to make sure the baby has the best possible start in life even though they've been identified as having problems. So, as I said, the bulk of my work is with premature babies, and it's been, as I say, apart from dealing with babies, I also deal with their families, because a baby isn't without their supporting structure. So a lot of my work, although it is about looking after the baby itself, it's also about looking after parents and taking them through that journey, which is quite a journey. Anybody who's been to an intensive care unit, it's what we describe as a bit of a roller coaster. So you start off and they look at these babies who look, most parents have never seen, especially the ones that are very premature, have never seen babies who look like that. They are very different to normal babies and babies that you possibly have seen in the news, because many of the babies that you will see after their journey look healthy and well, and these babies are very, very small. So this is the smallest baby I've looked after, is about 450 grams. And if you think that the average size of a term baby is about 3.5 kilograms. So this is an average baby. 7 babies can fit into that average baby in terms of size. So they're very small, and they're very ill, and they're very immature. However, there are lots of supporting structures that I have to look after babies like this. So the first thing parents will usually ask me is, one, is my baby going to live? And secondly, when will they go home if they do? And what I am trying to achieve in that period of time while they're in hospital, I'll concentrate first of all on the premature babies, is babies, I'm trying to mimic the in utero environment. So I'm trying to do everything that a mother's womb would have done. So we put them in incubators, we try and provide them with enough nutrition, oxygen and warmth. And the answer to when they will go home is usually when they can breathe for themselves, when they can feed for themselves, and when they can keep themselves warm. And the keeping themselves warm, one of the reasons why big babies can keep themselves warm is because they're born with quite a big padded fat layer. So if you look at a healthy baby, it looks quite fat in a sense. Premature babies don't have any fat at all. So it's impossible to keep themselves warm. And if they're cold, that can actually cause quite a lot of damage to their brain. And so it's really important for us to keep them warm. So the incubator is, and many of you will have seen incubators, is the main source of help when I'm trying to make sure that these babies survive to the end of their time with us. We also have to find a way to feed them, because babies don't actually develop the ability to suck until about 33 to 34 weeks. So about 6 weeks before they should have been born, that's when a baby can suck. So any baby born before that time, it will mean that can't suck, and we've got to find a way of giving the babies some food. And the other thing that we do is provide them with the necessary ventilation. So all our babies who are quite immature are put on life support machines, and the life support machines will do all their breathing for them. So it can be quite complex. And anybody I've taken to our unit, so parents or visitors, are actually quite shocked about the amount of monitors that we have in the room, the amount of tubes and wires that we have connected to the babies. Because they're so small, everything that you see in an adult intensive care unit, what we do in a neonatal intensive care unit, but everything is made that much smaller. And over the years, even in my career, things have got better for babies. So when I first started off, I've been a consultant for 18 years. When I first started as a neonatologist, the survival rate for the very small babies was quite poor. There was a national study done in 1995, which showed that if you were born at 23 weeks, only about 20% of babies survived. In the neonatal intensive care unit in which I work, and this is replicated across the country, that survival rate is now about 70%. So a lot has been done in the last few years in helping these babies to survive longer. So that's sort of in general what I do. But the things I thought I would talk about, because I thought, what would parents who are on this call want to know about? I don't know whether there are any additional health professionals, but I thought in general, what would parents want to know? And I thought about myself and what I would want to know to give my baby the very best start in life. If I happened to have a baby in a premature unit, or I had relatives who had children on my unit, what would I tell them? So firstly, what's the things, because when you have a baby in a unit like this, you feel quite impotent as a parent. When you have your own baby, you are the main caregiver. You do everything for your baby. And this is somehow taken away from you when you have a baby who's really sick on a neonatal unit. But I say to parents that you are really, really important in your child's life. And so I say, what are the things that you can do? So the very first thing I advise parents to do is that you need to be there, because you will become the experts of your baby. Don't worry about all the wires and the monitors. You will see things that other people don't see, because the people who will see that baby more than anybody else are the parents. And the way I explain that is that as a neonatologist, I come round and I give my expertise and I do a ward round, and I do that twice a day. So that means that the maximum time I'll spend with each individual child is probably about half an hour a day. And we have a range of neonatologists, and everybody does a ward round. So each of us I'll have my week on take. Another neonatologist will come and have their week on take. And then you have the nurses. So the nurses are a real integral part of providing care for premature babies. And they will do an 8-hour shift, and they'll do their 8-hour shift and they'll go home, and they maybe do 3 8-hour shifts a week, and they might have different babies. But you as a parent are there all the time. So we encourage parents to be part of the care. And that means that you can notice subtle changes that between doctors and between nurses, they haven't, because they're changing all the time. And with time, you can tell some of the things. And I always listen to parents. So if a parent says to me, yesterday, my baby just looked different. He wasn't moving. He was moving slightly less than he was today. It's just such a subtle change, but parents are really important in being able to identify that. So the first thing I say to parents is be there. The second thing that if nobody takes anything else away from this talk, if you can take this away, is about the importance of breastfeeding. So for term babies, what I say to parents is that it's your choice. Although as a pediatrician, I would always emphasize the need to and advocate the need to breastfeed, because breast milk provides more than just nutrition. When I look at babies who come to my clinic and I see the ones who have been breastfed and the ones who have been bottle fed, there is a difference. The weight gain is different. Their skin is just glowing. We know that there have been studies that have been done that show that they have effects on development as well, and that's much more subtle. I won't be able to tell in clinic, but I also know that they're able to transfer immunity to the baby. That at term is important, but prematurely is even more important, because when you're pregnant, over the last in your pregnancy, different things happen at different stages. So at the beginning, it's all about developing the baby, setting down the cells that make the bones and the skin and the muscles. The next phase of pregnancy is making sure those things mature. And the last phase of pregnancy is just growth and making sure that the mother transfers immunity of some vital diseases to the baby. So the baby arrives, if it's born at term, with things that help it to fight infection. Now, if you're born prematurely, you miss out on all of this. And so breast milk becomes even more important. And it's quite difficult, because you might be saying that, well, I would take the choice to breastfeed, but remember that the cues that a mother has to breastfeed when a baby's at home, so the baby wakes up and cries and nothing will settle that baby except breastfeeding. In the hospital, you don't have that cues. And to have to wake up in the middle of the night when your baby is sick in hospital to breastfeed every 3 hours can be quite a challenge. But I see the breast milk as a form of medication. It is that important. And there is no point us investing all the things that we're investing if this really, really vital aspect is missing out. And so those are two things that parents can do. You need to be there and be a partner in your baby's care, and you need to be able to provide breast milk. So I say to dads that your wife, your partner, is a queen at this stage, and that all she needs to be doing is sitting down with her feet up, watching TV and eating. Because if you need to be that partner in your child's care, is to make sure that your wife has no stresses, your partner has no stresses or strains and can concentrate on breastfeeding her baby. So those are two things that you can do as parents. And I find that goes a long way, because also there is a kind of nervousness when you're going to be discharged. If you spent all that time in hospital and you've never actually been able to look after your baby by yourself, when you're discharged, on the day of discharge, when you're not there with all the monitors and the alarms that indicate that something's going wrong, you can feel quite worried about it. So one of the things that we advocate is that parents spend a couple of nights in hospital with their baby, so we've got rooms for that, so that they can build a bit of confidence before they go home. So that's the end bit. So those are the two things I say to parents. But in hospital, as I've said, the three areas that we look at are I'm particularly interested in is premature babies who are born who've identified with problems. And then there's another group of babies who weren't expected to have problems. So even up to a day before birth, we didn't think that there was going to be any problem. And these problems have come about in either just before birth or maybe on the postnatal ward, where there might have been problems that were there antenatally that weren't picked up. And these are really difficult because different decisions or different way of approaching things may have turned out to have a really different outcome. And these are the babies who have brain damage from a lack of oxygen, either because of what happened during the pregnancy just at the end. So maybe a decision to do a cesarean section some minutes earlier might have led to a very, very different outcome. Decisions about coming to hospital when you stop feeling the baby moved might have had a very different outcome. And those are the ones that are really, really challenging. It's not that, I mean, every baby is precious, but for some babies, when they've actually got to the end and just a matter of a decision that is different in terms of minutes can have such a profound impact. So this aspect is quite important, because what has happened over the years, we've seen many of these babies do better because there's been a real emphasis on the ability to provide good resuscitation. And what resuscitation is one, you need to recognize what the problem is and have people in the room who can provide the support for this very quickly. And that is providing oxygen and helping the baby to breathe straight after birth. So why this is important is that I work in a high-tech neonatal unit, but what I've just said can be anywhere in the world. And we have seen areas across the globe where the instance of cerebral palsy from there's a condition called hypoxic ischemic encephalopathy, which is a lack of blood and oxygen to the brain. And if that lasts for more than a couple of minutes, the longer it goes on, the more the disability. And there's the cohort of babies who, because of poor decisions and just before birth and lack of support after the baby's been born, these babies have problems that will be life-changing and last throughout their lives. Now, good resuscitation can address many of those problems. And even in the UK, by ensuring that all units where there's a baby going to be born have people who are trained in delivering good resuscitation. This can be delivered by midwives, can be delivered by birth attendants. In my hospital, obviously, we have junior doctors. So everybody's got to be well trained in that. And that's something that's called newborn life support. And it's basically a day's training, but the impact is great. So anywhere in the world where there's a possibility of deliveries, everybody who attends deliveries should have this training. And I say a day, but in actual fact, what you need is a resource bag, which is a piece of equipment that's actually quite cheap to procure, but just being able to provide support at birth can have really profound effects. Now, although my practice is mainly in-house, I also follow up babies when they come back to clinic. And I'm also involved in making sure that the babies who leave the hospital are looked after well. So all the work we've done in hospital is continued, because no point of us providing all this really high-tech and really expensive care in hospital without that being continued in the community. So babies who need support are looked after by community paediatricians, but also we know that babies who have been born on the postnatal wards and go home can develop problems. One of the things which I think is quite pertinent to the Afro-Caribbean society and babies is the development of jaundice. So jaundice is a condition that you develop because babies' livers are a bit immature. So it's a combination of things. So you're born with a liver that's slightly more immature, even as a term baby. The second reason is that when you're born with something called fetal blood cells, and that over a period of time transfers to adult blood cells. And it involves the breakdown of those fetal blood cells into adult blood cells. And the liver mops up any jaundice that is picked up from that. But because it's going at a rapid pace, very often babies become jaundiced, and it's usually quite mild and can be, doesn't need any intervention or any treatment. But there's mild cases, but then there's some that is slightly higher, and that needs treatment with phototherapy. Now, the difficulty is that if it's untreated when you do need treatment, it can actually go into, the reason why we concentrate on it and we don't like having bilirubin in the blood, circulating the blood, is that when it gets to very high levels, it can cross into the brain and it can cause brain damage. So all the treatment we give for treating jaundice is to try and limit the amount of bilirubin that crosses into the brain. And this is only to do with children and babies, because you've seen lots of adults. Adults have jaundice for a variety of reasons. And one of the commonest reasons that you will know is if you have anybody who's had hepatitis where they look yellow, or you might have seen people who are addicted to alcohol, and they also have jaundice because their livers have failed. In adults, it doesn't cause the same problems that it does in children. So you're protected from having brain damage because what the blood-brain barrier in an adult is already well formed, but it isn't in a child. And this has caused problems because it's actually quite difficult for people to recognize jaundice in Black babies. And this condition of kernicterus, because there's a recognized treatment, if it happens, it is it's actually quite a serious case. So we collect the numbers across the UK every year, and although they're going down, what we've seen is that worrying trend of it only happening in Black and Asian babies because people haven't recognized it early enough. So the only thing one of the things that we've decided that we can do to help is buy something called bilirubin orbiters. And these are devices that we can give health visitors and community midwives to place on the baby's skin. So it takes out the guesswork as to whether the baby is jaundiced or not, and it will give you a reading of how much bilirubin is in your body. Because we know that babies were presenting late because the midwives and health visitors would look at the baby, wouldn't notice that they're jaundice and think it's okay. And by the time it became apparent, it was too late, because the jaundice had built up to such a level that everybody could see it. So this is one of the things that we've been able to implement. And I know that not all areas in the UK have their health visitors and midwives going out with bilirubinometers. But one of the things I've been able to do is that in the last couple of months, because of the fact that we have, we've had COVID and there are more babies not accessing care, we've been able to say that every area has got to now invest in these bilirubinometers to make sure that we can find babies with this condition earlier on, because it's completely preventable. And the problem with the brain damage, it is not reversible. So if you have a baby who's had this, they'll be damaged for the rest of their lives and there's nothing you can do about it. So the best thing is make sure that you prevent it. The other thing I thought I would talk about today is the impact that COVID has had on my service. Now, luckily for us, at the beginning of the pandemic, we knew, because of stories that we'd heard from China and from Italy, that babies weren't really affected. And as you've heard, children are not, and babies were less so. But we had to alter the way we deliver service, because we had mothers who were coming into hospital with COVID, and we weren't sure about the implications of a baby who was born to a mother with COVID. Would she pass it on to her baby? If she passed it on, what would be the implications, and how would that baby manifest the symptoms? And although the research has been coming out, lots of people have done different things. So some of the things that they did in China, and we weren't sure whether this was why they hadn't seen any impact, we thought it was actually quite severe, was to separate the mother and the baby for 2 months. Because they didn't know what the impact was, but we just felt that was, if there was going to be no ill effects, then that just felt too draconian. So we asked our colleagues in Italy what they had noticed, and they found that they were able to, they breastfed the babies there from women that had COVID, and there were no ill effects. And so we're able to draw on our experience from our Italian colleagues and not restrict the babies and mothers who had COVID. What we have done on the unit is that if you are positive, that you won't be able to visit the unit, because we have vulnerable babies, and that does mean that positive adults could pass it on to the babies. So we've put babies in who have been born to mothers with COVID. We've looked after them in exactly the same way, but we have cohorted the babies, and we've tested them on a regular basis. And once they've been negative, we've put them back into the general room. So that's the impact it has had. And while that sounds as if it's quite a it sounds quite simple, it was actually quite involved, trying to put babies and trying to decide which rooms they went in, and making sure that the footfall on the unit wasn't as much as it had been before. The other impact it's had, and remember I talked about having the parents as partners in their care, is that because of COVID, we've had to limit the number of people coming through the unit, and that has meant that we've had to limit parents coming onto the neonatal unit as well. We've now stepped that back up because we've realised that babies just don't get COVID, but the impact that has had across the country is that parents haven't been able to visit as much as they would. We are trying to encourage neonatal units to reverse that decision and allow parents to visit, because we do recognise, as I've said, that parents being involved in the care is really vital. So I just wanted to, I've been seeing some of the comments now, and I've seen one of the comments that says that those mums who can't breastfeed will feel that they're letting their babies down and too much of a guilt trip. And I completely understand your point. Now, I say that for breastfeeding, it's a personal choice. So when I've spoken to parents who have babies who are born at term, I say this is a personal choice. As a pediatrician, I cannot meet a parent and not advocate what I know is the best for your baby. But at the end of the day, just like everything else in life, it's a personal choice. However, it would also be completely wrong for me to not explain to parents the positive impacts of breastfeeding on a baby. And whilst it might be guilty, there might be a guilt trip. Imagine if I hadn't told this parent about the benefits of breastfeeding, and they later come to learn that if only I'd put in that effort, this is the benefits my baby would have had. And that's happened to babies in our unit. There's a particular condition that premature babies have called necrotizing enterocolitis, and it's inflammation of the gut. Now, not all babies have it, but what we know is that if you're breastfed, you're largely protected from this condition. And you might feel inflammation of the gut. That doesn't sound very serious, but it's actually quite serious, and babies die. So the ramifications of a premature baby getting necrotizing enterocolitis is that, first of all, you have the inflammation, you have to stop feeding for quite a long time. You can also have parts of your bowel that develop holes and you need surgery. So remember I told you about the smallest babies I've seen, which is about 450 grams. So we have babies at a kilogram, 500 grams that need surgery because of developing necrotizing enterocolitis. And the other thing that it does, you can also end up losing part of your bowel. And that means that you have a shorter gut for the rest of your life. So if I have parents who come onto the unit and one of them develops necrotizing enterocolitis, and they say to me, why did this happen? And I say, well, for some babies, it's just, you know, why do babies come premature? Why are some babies born with cardiac conditions? We don't know. But for necrotizing enterocolitis, although for the majority we can't really tell, what are the things that we know definitely protect the baby? And one of them is breastfeeding. So I've had parents in tears saying that I wish I had done this. We have parents who, so I understand that there are some parents who might not be able to physically breastfeed, but that is very, very rare in my experience, very, very rare. And the other thing that people worry about is the amount they breastfeed. So when we start breastfeeding a baby on the neonatal unit, we start with 1/10 of a teaspoon. 1/10 of a teaspoon an hour. So the volumes don't really matter. What we need is just some of your breast milk to make sure we confer the benefits on the baby. So I cannot overemphasize this, because when parents say to me, what can I do? This is something that they absolutely can. So thanks for your comment, but I just thought it was important to do that. And we do it in a supportive way. We supply people with breast pumps because it is such an important thing. Lorna, I've seen you. Hi. Lorna she's just, I don't know, she's my sis, that's what I'll say. When I was a trainee, I worked in a hospital, not the hospital I'm working in now, it was called Hope Hospital, and it had a neonatal unit, and which is now closed because service has been redesigned and redesignated in Manchester. It was quite a big neonatal unit. And one of the things that continues to happen is that many areas in Manchester, because we have a unit with finite capacity, and part of my role in managing our unit is that when we have premature babies who are born, and again, because you live in Manchester, you might come across this as well, that they will say, you'll have a family member say to you, my baby's in St. Mary's, but they've said, I've got to move to Tameside or Stockport. Can they do this? And we can. And the reason why we can is because at St. Mary's, we look after the sickest babies in the region. And once we have looked after once we've looked after your baby and we've got them to the point where they're now doing better, we need to make room for other very sick babies. And so babies who are not yet ready to go home will be transferred to their local hospitals. And this is really difficult for parents because they might say, I chose to book at St. Mary's because I like the facilities. I chose to book at St. Mary's because I know there are experts there that can look after me and my baby. However, if we don't transfer babies who are able to be looked after in other units, what happens is that these premature babies are transferred to Liverpool, to Sheffield, to Leeds, because there's no space in our unit. So it's really important that when the babies get to the point where they can move on, that they are. And we've had a bit of negative publicity. I remember being on the front page of, my name was on, it was a horrible time for me. My name was on the front page of Manchester Evening News once, because we transferred a set of twins to a local hospital, but we only transferred them when it was safe to do so, when they had got to the point in their care where this care could be delivered well by another hospital, and we were all work as partners so that we could continue to deliver the really intensive care and the care that can only be delivered at St. Mary's. So I met Lorna when she had premature twins. And although at that time I was what they called a junior doctor, so I was progressing my career and I was getting towards the end of my training, I was very opinionated. And Charles sent me I think he sent it to for those of you that are on the CAHN WhatsApp group, it was a paper that said, if you are looked after by a black baby, a black doctor, the black baby is looked after by a black doctor, that the outcomes are better. I looked at the paper and I think I have some views. So one of them is that we are able to recognize, so if I went onto the postnatal ward and there was a black baby with jaundice, I would be able to spot that straight off because I know what black skin looks like. So my white midwifery colleagues and white doctors might not be able to spot it as quickly. So that's one of the benefits. But also, I understand when, and I get this quite a lot, when we have the cultural nuances of having a baby and how you interact with your baby on our units. So I understand when I have African parents who decide that they want to pray for their baby at the bedside, or they bring their pastor in and people would look at them, they would look at them as if they were a bit odd because they brought their pastor in and they're praying very loudly, and maybe the pastor is praying in tongues by their bedside. Now saying, no, that's a culture and there's nothing odd about it. That's the way they need to express their desire and their faith and their hope for this baby to do well. I also, so I can nip things like that in the bud. I've also been able to advocate for parents who are, so we have a wide range of parents in our unit, and we have those who are more affluent, and we have parents who need to go back to work because the baby's been on the unit now for 3 months. They've used up their maternity leave. They need to be able to feed their babies, and they go back to work and perhaps cannot visit as much as they would have been before. And you have nurses making comments about, why is this mum not visiting? And I say, look, you've got to really look at the family as a whole and not make subjective comments or opinions about parents who cannot visit as much as they would do, because it's not just about the subjective comments, it's about how they manage that, maybe decisions about whether, I'm really sorry about this, my next door neighbour's alarm is going off. Can you hear it? I hope it's not interfering too much.
We can hear you.
You can hear me, sorry. Yeah. So it's about subjective comments about whether you're going to involve supportive services, and that in a sense puts a label on the baby. Also, many of you were brought up in African and Caribbean households where the telling your child off was just part of the course. I think for many African and Caribbean babies, smacking their child is just part of the course. And I've had parents on the unit where I've had to go to explain to them that you cannot do this. You cannot bring in your 2 and 3-year-old and smack them on the unit and think that people will not intervene. They will. So I can have a quiet word with them because I understand the cultural nuances, that you cannot shout at your baby. But I say to the nurse on the unit that when we have white parents who bring in their babies who have orange juice in a bottle at 2 years old, that again is another cultural nuance that you won't find Black people doing, but it's just as bad. And we need to address both of them with the same severity. So I also, one of the other problems is that, which is a difficult problem, is whilst I look after all these babies, remember I talked about survival rates? I talked about survival rates because not all babies will survive. And that's just a sad fact of what I do. We try and save as many babies as possible, but because they're really, really sick, some of them will not survive. Now, I can advocate for some of those babies and about the way we put that across, and where we have to explain when the babies are really, really sick and what might happen. And we also explain when it looks as if it's inevitable. But I have been involved with babies where I think that it's too soon to be talking about withdrawal of care, because sometimes, especially if, so when you're looking after a baby and the ventilation is not very good, they're not managing to feed and they're not growing, and also that maybe they're not responding to the medications, you have to have the conversation with parents, because what you don't want to happen is that if the baby doesn't survive and you haven't had that conversation, they haven't had time to prepare themselves. But I always think that those conversations should be done sensitively, because as I said, nobody starts off a pregnancy thinking that this pregnancy will not end up with you taking babies home. So an admission to our unit means that it's already the dashing of some of those hopes. But secondly, when you come to the unit, you're filled with hope that this baby will survive. And then after that, and sometimes after quite a long course of treatment, the baby's not responding to treatment, and sadly, the baby does die.
More comments in the chat box for you.
Sorry, are there some things in the chat
box?
Yeah.
So Sherry as well, she said you were in charge of her son when he was born back in 2002. And he suffered.
Hi, Sherry.
Hi, Doctor.
Yes. So in actual fact, the question of ADHD, in fact, I was asked that question just a couple of days ago in clinic. And ADHD is a particular diagnosis. And people can be inattentive without having ADHD, but it's like a banner of saying that, okay, you have a whole group of people who have headaches, but there are various different reasons for headaches. And if you use the wrong treatment, it's not going to work, because the underlying basis for the reason for that headache is not the same. So the same thing with ADHD. Now, babies who are born prematurely, the more immature they are, the more likely they are to have inattention. And I've seen it with lots of premature babies. They have a short attention span, but the drugs that they use to treat ADHD generally are not for premature babies, because the reasons for their prematurity, for their ADHD, are different. It's prematurity. So I absolutely understand where you're coming from, Sherry. And I explained it to this parent because the people who are treating it just want to have resolution of the symptoms, but I actually think that what they need is to find different strategies that you will understand best for your child. So I always think that the experts in looking after a child are the doctors and the parents working in partnership. And I always say, don't be cowed by the fact that you work into this unit and there are so many, there's just so many things in the room. Like Lorna said she was actually quite outspoken. And I find that it's better to speak your mind, and ask the professionals to break it down in a way that you understand, because it's your baby. And whilst they're the experts, it would be like you going to the hospital and you being explained what's wrong with you. You'd want to know why it's going on. You'd want to know it's in the most basic level, and it's no different for your baby. So don't let anybody bamboozle you with big words and things. Ask them to break it down in a way that you as a layperson and this person's parent can understand. And I think that's really, really important.
Because there's another question here. Why are Black babies more likely to be premature and also likely to weigh less and end up in neonates?
So I don't think anybody really knows why they're more likely to be premature. And I'm not actually, I think when we do, the babies that we know are smaller than other babies are the Asian babies. If we have, what we now have developed is what we call individualized growth charts. So if you're pregnant and you go to clinic, in the past, when I first qualified, they had these growth charts for babies that were not individualized, and they just plotted everybody in actually the same way. So if you were 5'2", and so one 5'2", dad 5'4", you'll be plotted on the same growth chart as dad 6'7" and mom 6 foot, which you can see that doesn't make sense at all. So now what they have is individualized growth charts for each individual baby. And when you plot that, you can actually see. And so when you say babies are smaller, what we do is now plot babies for their parental heights. So the number of babies who are born who are smaller than average, we know that Asian babies are much smaller, but African babies and Black babies are generally not. They're not smaller than others. We know that in this country that there are more premature babies within the African and Caribbean population, but I'm not sure why. I'm not sure why.
Okay, there's another comment and a question in the chat box. So from Esnat, thanks for your comments on jaundice. I live in Tameside and I've struggled to communicate with the community midwives that my son had jaundice. He was seen by 4 midwives, none recognized his eyes were yellow until my husband and I pointed out.
Okay, because of what I've said about jaundice, if it's got to the point where you can see it and you're not listening to, and you're not being listened to, I would go to a pediatric, ask to be referred to a pediatric, attend pediatric A&E. And that's because of all the babies that we've seen in the past year with kernicterus, not all, about 80% of them are babies who are Black and Asian. That's because it's not being recognized. And remember what I've said about kernicterus. Kernicterus it causes brain damage which cannot be reversed. So if you can see the jaundice, you take them to present to a pediatric A&E and get the test done. Yeah.
So
it's very frustrating. It's very frustrating. But as I said, it's something that they cannot see because the skin is quite dark. And this issue with the bilirubinometers, and this is an example, Estat, it means that they didn't have these bilirubinometers. And I'd say one of the things that I'm proud to be able to do, so as obviously my training was as a neonatologist, and when you start out being a doctor, when you dream of being a doctor when you go into medical school, one of the things that you think about is that you're going to do all hands-on care. But I'm really fortunate and quite proud that my career has taken me in different paths, and I'm now in a position where I can influence policy. And this is one of the policy decisions that I've been able to influence, the being able to supply all health visitors and midwives with this bilirubinometer. So this was something that was agreed to be funded by NHS England just last week. And this was because of my direct intervention, because I've explained to them that we cannot continue to have babies who are having this condition when there's something we can do about it. So really, when midwives and health visitors are called to see babies like this, they should be using this equipment instead of eyeballing and having arguments with parents.
Okay, Ngozi, 2 more questions for you. One is in reference to Embrace, that Black babies are 122% more likely to die within the first 28 days. And, has COVID impacted this at all or worsened it?
Okay, so COVID has had no impact at all on mortality. What we're still looking at the figures, but one of the things we found with COVID was that in actual fact, there were two things that we noticed. And some of this is about people telling their individual stories, and we really need to collate this across the country, and we're doing that at the moment. So one of the things that we noticed was that the neonatal units were incredibly quiet. So our activity went down. And we're not sure why that would be, because people are still pregnant. And one of the things we wondered and postulated was that because everybody was in lockdown and not going to work, and for many areas, pregnant women were told, I know in healthcare, were told because of the impact of COVID, we didn't allow any of our pregnant nurses to work. So if you can think about somebody who is doing 8-hour shifts, coming to work and doing that until maybe about the 37th week of pregnancy, because they want to maximize their maternity leave. And then on the converse, being told, no, you can sit at home now with your feet up. And what that might do to the cervix, because we know some of prematurity is that the cervix, which is the opening of the womb, just gets bigger for no reason. And that can precipitate prematurity. So we wondered why the fact that we had many more pregnant women at home, not working, whether that had an impact on the number of premature babies we're seeing. And when we analysed this, because this was just chat between neonatologists, because everybody was so busy, I mean, A&Es were quiet because people stopped coming because they're worried about coming to hospital without COVID, but our intensive care unit, the adult intensive care unit, was really busy with people with COVID. So that was one. The second impact that we also is anecdotal, but we're collating the data and we'll have more data in about 6 months, is about babies who suffered from the HI I talked about, which is brain damage from lack of oxygen to the brain. Now, many of you that are pregnant will have heard of the Count to 10 campaign. So that is pregnant women counting the number of kicks their babies do. Now, if your baby is not kicking, that's a sign of a problem. And it means that there might be some concern that the baby's not managing as well, then you come to hospital. Because pregnant women were worried about coming to hospital unless they were in labour, there's some subtle signs that we felt, because people were not accessing care quickly, that babies who mother would have come earlier were not coming on time, and we had more babies with HIE. This might have been, anecdotal, but I saw a couple of babies that women presented late, but we're going to collect the data to make sure that this was a true reflection. So the other message, although I'm not an obstetrician, I look after babies, so I work very closely with my obstetric colleagues. One of the messages is that if you are concerned, COVID or no COVID, please present to hospital when you're pregnant, because they've organized the hospital in such a way that they keep non-COVID patients away from the COVID patients. So you're not at risk coming to hospital to find out whether there's any concern with your pregnancy.
Thanks, Ngozi. Another good question from Lorna. Although my sons are 21 years old, Lorna, do you want to unmute and ask your question?
Yeah, I can see, but Lorna, hi.
Yeah. Hi, Ngozi.
Hi, Lorna.
Thank you so much. Ngozi is my guardian angel. Everyone should know that.
We had an experience, didn't we? It was so hard. It was so hard. It was hard.
We could write a book on the.
We could write a book, Lorna.
Ngozi.
Because although Lorna was an outspoken parent, I was an outspoken junior doctor, and I didn't agree with it. So,
I don't think they knew how to handle this force, did they?
They didn't.
I remember, actually, I was that parent that Ngozi described, because I started off my experience at Manchester Royal Infirmary, and I didn't want to be moved to Salford. It was awful being told that they didn't have enough, God, it's so long ago. They didn't have enough incubation space for twins, so I had to be moved to Salford, which I thought I didn't want to. Anyway, I went along with it. Turned up at Salford. I thought I'd entered the twilight zone. Everything was dark. There was no people. I thought they were going to kill me or something. I did. I thought they were going to do to me. Anyway, I did this. It's the weirdest experience having a premature baby, because you don't actually see your babies. You go in, you have a delivery with about 12 people in the room. it's very frightening. And then you are taken to your lovely room, and you don't actually see your babies for about a week. You get a photograph, you get a Polaroid photograph. That's what you get, don't you, Ngozi? Do you remember?
Yeah, but that's changed now, Lorna.
Well, I know. I'm just saying my experience.
Yeah.
And it stays with you because I can remember it like it was yesterday. But my thing was going into that unit, and when the day Ngozi walked in and our eyes made four, everything changed for me from that day. I had a guardian angel sent to me in Skaboo, and I'll never ever forget that experience.
I know.
You know.
Thank you, Lorna.
And it was very challenging, but Ngozi would support the questions that I asked, where the other consultants were telling me that I was asking too many questions.
Yeah.
Ngozi would say, no, she's actually reading the, what's that thing called? You write all the reports in. I was reading the files. I was reading my children's files, and I was being told why was I reading them, and then I was saying, well, they're my children, and Ngozi would support me in that. But with regards to my sons now being 21, I definitely see, I've watched them grow, obviously, and they function differently.
They do, they will do. And our Lorna's talked about 24 weeks. That is, when you think about it, they were just over halfway their pregnancy. They are miracles. To have 24-week twins survive to this age is, and that was, they're 21 now. So that was many, many years ago. And every year we learn more, we do things better. And some of the things that we did in those days, we do things differently now. But the brain is still developing. And the way I describe the brain to parents is that if you think of a peanut, it's nice and small and smooth, and you think of a walnut. So everybody's seeing pictures of brains. Now, Lorna's baby's brains were like peanuts. They were smooth. Those sulci and gyri that you see in adult brains were not there at 24 weeks. And that meant that all that brain development that would have taken place inside the womb had to take place inside the incubator. And when you're really, really sick, then the brain does not develop as well as it should. You know, in the incubator, we cannot replicate as much as we try the womb. So the incubator is a proxy for what we're trying to do, for what the womb tries to do. So we're trying to do all sorts of things, minimize noise. And at that time, Lorna, if you remember, there wasn't the emphasis on minimizing noise and minimizing light that there is now. It was all to do with the medication.
Oh, and so is it all quiet now? Is it all quiet now?
We have quieter rooms.
Very busy room, very noisy, very
noisy,
active. And I would stay there all night, wouldn't I, Ngozi? I wouldn't leave the room until 5 in the morning, and it was.
You would.
Yeah.
And Lorna noticed things that other people didn't.
Yeah.
And I remember that day that intervened, because we had a consultant who'd said to Lorna that her baby wasn't going to survive. Yeah. And in my heart, I didn't think so. And it was really difficult for me as a junior doctor to stand up to the consultant.
Yeah.
Which in the end I did.
You did. You stood up for me, because I told you, Ngozi, that wasn't the first time that they told me that my child was going to die.
Yeah.
And it was CAHN Day. And they had taken me aside into a room with 2 white consultants and told me that you need to get used to the fact that one of your twins is going to die. And we've made an appointment for you to meet a mother who's lost a twin. And I kicked off and left the room. And that's when I told you, Ngozi, that they've been talking to me like that for a few weeks.
Yeah. It was sad. It was.
Yeah.
And I know it could have been handled better. And, you know, when I read that paper, I know that when I see Black families, the pride in which they look at me, I know. And I know they see me as the fact that they've got somebody they feel is different. It's like when I walk into a hospital and I see a Black doctor, even me as a doctor, I feel a calmness. I don't know whether the doctor is good or bad, but I just feel that they will understand my needs better than a white doctor. I just do. I can't explain it. I don't know whether it's true or not. I've got white colleagues, and I know that they're really good white doctors, because if not, I wouldn't have been able to flourish in my career. But I know, even without knowing anything about them, that when I see a Black doctor, I think, yeah, he'll get me. He'll understand, you know, my nuances. He'll understand things about Black skin. He'll understand the emphasis that we place on cancer, you know. So I do feel, I feel more at peace, and that's me as a doctor, and that's the truth.
Thanks, Ngozi. One more question from Teresa, and then we run up. So Teresa, if you can unmute yourself.
Yes, hi.
Hi, Teresa.
Hi. Yeah, you spoke a lot of good things, and I'm really pleased that, you know, you've gone so far in your career. But I was just thinking, you know, like you were talking about, like when a Black baby has jaundice and it's not sort of recognized maybe by the white doctors.
Yeah.
I just wanted to know now, like in 2020, when we have our young students going to university to become a doctor, do they teach them that this is what will happen in a white baby, but then when you have other babies of other colors and things, that you have to look for something different? I mean, because a lot of the times you do notice that it's the Black parents who have to be like arguing and fighting to say, I don't think that is the case. Can you not like do a few more tests? And eventually the doctors will then give in and do it. And I think if they know this from training, that maybe this is something that relates to sickle cell, or this is something that relates to jaundice, but in the Black baby, then, you know, time isn't wasted trying to find the solution.
I'll answer that quickly. I understand. So there are two things. One is, because of our experience, you know, my grandmother used to say, I'm not going into MRI because Black people, if they go in, they come out dead. She said that all the time. Now, the thing about the jaundice, yes, the textbooks are being, so in fact, there's a Black doctor who's just done a skin book about rashes in different things in Black skin, and for lots of different things, but it's one been dedicated to skin. Because I remember when I first arrived in this country, we were talking about bruising, and they said when it turns green and this, I remember thinking, what are they talking about? I'd never seen bruising in white people, so I only knew bruising in Black people, and it's generally it's not as rainbowish as it is in white people.
Yeah.
So this doctor, we've now got a book that they're distributing to all medical schools about different skin conditions, and there is lots of things available. So yes, they're addressing that. But the other thing is that what I find is that it either goes two ways. One, where I think that Black people don't speak up enough because of, you know, the how they consider professionals maybe. And I know that Charles advocates when things go wrong. But the other thing is that, and this is why I feel I'm able to help, is because someone with my grandmother's experience who already feels that I'm in a place of, this is an adversarial experience. And so if I don't make a noise, if I don't challenge everything that happens, then my outcome will not be great. This is why I can advocate, because on the whole, I'd say 80% of the experiences that I know that patients encounter are good experiences. So the bad experiences are in the minority. And so when and what I've been able to do in my role, either so with Charles, is give people an explanation for what's being said, so that if it is true, and if that's the right course of treatment, that you can accept that. Because I find that adversarial interactions with medical staff don't help your course within the hospital sometimes, because people become worried about speaking to you. They send the most junior nurses to look after you, and so if that's the right course of treatment, then that's the right course of treatment. But all those aspects of Black care that have been forgotten for many years, so things like sickle cell, we know that we're doing a lot more. There's a whole program devoted to sickle cell, and many of you may have come across Dame Elizabeth Agnon, who, when she was telling her story, said that when she first looked in the nursing textbooks, there was nothing at all about sickle cell. But of course, that's changed a lot now. And the skin conditions is as well. But also what I tend to do is take the students when I see it, because when you see it in the textbook, it's different than when you see it in real life. So if I see babies with jaundice, I tend to point it out. The other thing is that, you know, when they say describe somebody as being blue, that means that they lack oxygen. It's very different in a Black baby. So when I see Black babies who are cyanosed, I point it out, because seeing it in real life, even in videos, is different when you see it in real life, and you don't tend to forget if you do. So I make it a point that when I have student doctors or people that we're mentoring to come around to show them these things. So that's the difference that I think Black doctors make, because they know that it's there in the textbooks, but they know that it's something rare that they wouldn't have seen. So you take people to go and see these things.
Yeah, that's good. Yeah.
Yeah, no, it is. It is. And that's why I'm encouraging people to, I've always said, before the COVID pandemic, I have mentored 9 Black students, 8 who are either medical students or doctors, who are brought round to our unit to do their attachment. I've always said that I will always, because I used to see it, I'd be in the room when I first started at St. Mary's, I was the only Black doctor in my unit. And people would write in and say, can we do an attachment? And they just say, well, no. And I'd look at them and say, well, hang on a minute, I've got time, even if I didn't, I've got time. I'd like to take this doctor on to come and do their 2 weeks. And that's the difference about having Black doctors who can make these changes. Because I know that if I wasn't there, they wouldn't have been able to come. And also it's about them when I'm doing the ward round, they can see that there is somebody who is just exactly like them. And out of these 8, I must say, sorry, Charles, 7 have been female. It just happened that way. It's not that I exclude males, but it just happens that way. But to see another Black female doctor, I remember one of them went back to her mum and said that she saw Auntie Ngozi in a different light, because to see somebody that's just like you, that is doing the ward round, it means you think to yourself, I can do this. And that is just so powerful. It's more than reading about it, to actually be there when somebody's doing it. I know it does have a profound impact on the students I've brought through.
Right, thanks, Ngozi. Amy, are there many junior doctors going into neonates? So that's a question from Lorna, and then you could give us your final words.
Yes, Lorna, there are Black doctors going into neonatal. I've inspired quite a few. I'd like to I can come to the focus group, because one of the things, like Lorna said, these experiences at the beginning, they never leave you. I remember speaking to, recently I spoke to a white woman who had a baby on, and she describes it as PTSD. She said the experiences she had at that time with her baby on the unit have never, ever left her. And when Lorna was talking about her experience, it made me remember this woman. And as much as we've done in neonates, I think we've got to the point now that we've got to have proper co-production, because something this woman said was that you cannot walk in my shoes. When you want to make a pair of shoes, you ask the person, if you want to fix it, the person who's wearing it. So that person tells you where it's pinching. So we really do need our parents, people who've been through this experience, to tell us their experiences so we can change it for the better in future.
Ngozi, as always, we're really, really grateful for your time. So as I put in the chat box, we're thinking of a focus group, and, just let us know if you're interested. Drop us your, send over your email or drop us a text, and we will send you further details. And it will be in early September. So thanks everyone for joining us. I think next week we have someone who will be taking us back to, kind of mental health. So we're going to confirm that in the course of the week. But on Tuesday, Dr. Hiba is going to take us through kind of weight management. And we all know the obesity strategy that has been launched by Public Health England with the hashtag Better Health. So we look forward to seeing you on Tuesday evening. And I've just realized the sun is out. So enjoy the rest of your weekend. And then we will see you on Tuesday. But Ngozi, thanks to Eddie, your husband, for all you do to support CAHN, and Auntie Elaine, she's ever so there, ever so present. Have a wonderful weekend, everyone.
Thank you, everybody. Thank you.
Yeah, thank you. Thank you.